Good morning, everyone. Yeah, it's time 10:01 actually. Okay. Welcome you all once again for another Abu Dhabi local chapter session. So it's my pleasure to welcome you all for this session, and uh, this is a very fine morning, and we are here to discuss the topic. It's all about time, right? Uh, as coders nowadays, I think you all are familiar how much time is nowadays. The usage of time is getting increased in the coding, right? And also how much that is be, even though if it is the codes are available already, we can understand how much it's been used nowadays, right? Because we just crossed the pandemic. We cannot say crossed because till now we can see many cases that's coming also. So but during the pandemic, that was our bread and butter, right? Almost all the claims, more than 95 percentage of the claims were outpatient claims are time based, right? We were coding by telephone codes, and some we will be charging by service codes. So it was totally different what is this time period we crossed, and now alhamdulillah things are getting better now. So but still now also we have this telemedicine codes, and these are being utilized now, right? Because we are a lot of services currently we are using based on time, right? For example, any education or any like telemedicine, physical therapies, and we can mention many a number of services currently are giving by time. Okay, so but the application of time is getting increased day by day, right? And when the utilization is getting increased day by day, the guidelines, the policies that's governing that service, it's also getting increased day by day, right? So as you all are familiar that the recently we have the new circular that is released in Abu Dhabi regarding telemedicine, right? So these are the lot of rules that's nowadays it's getting added day by day. Okay, so that's why we feel that this topic will be more important, and it will be many. If, for example, many people, even though if they don't get the chance to do this time-based coding, it's very important to know how this is being utilized in other areas, right? Because for example, if your facility is not having a telemedicine, or if your facility is not having a physical therapy services, then the coders will not have any hands-on experience how this is being coded currently in the other parts of the world, right? Even though if it is used in other facilities, they want some hands-on experience, some knowledge on the time-based coding actually. So that's why you feel you all can understand how much this is very much important. And also it's a very good session because this was based on the feedback that we received from our team members during the recent years. For example, whenever we ask the feedback at the end of the session, what is your topic, interested topic that you want to listen in the upcoming chapter? Members are saying many people wanted this topic as well, so it's one of the favorites that members requested. So we will try to cover almost whatever is the best thing we can cover in this session. So I hope you all are familiar with our speaker today, Mr. Sunil, right? So let us wait for him, and 1 or 2 minutes. He has some system issues. He's resetting his laptop. Just wait 1 or 2 minutes for him to join. Also, in the meantime, we can discuss on like a lot of updates. Like as I mentioned last time, many DOH circulars are nowadays being released, and a lot of updates, and these are all strengthening the coding here that we follow here in Abu Dhabi, right? Whenever more and more policies are added, that means you will have more governing rules actually, so it's very healthy for the environment, right? So a lot of guidelines, it will increase the value of the coders actually, right? So that coding field itself is getting better and better whenever more rules are getting in place, right? So that's why we can feel that 1 minute. Yeah. Okay. I think our speaker is here. So I would like to introduce. No need of any introduction for Mr. Sunil, right? Because I hope you all are familiar with him. He is our previous president for the local chapter Abu Dhabi, right? 1 second, he's trying to join. I will also.
Sheikh, you are able to hear me?
Yes, that I can hear you now. Yeah.
Okay, very good. Very good,
Okay.
very
On behalf of the whole team, Sunil sir, we would like to welcome you for this session as a speaker, and thanks for your support. Even though you are the president of Dubai chapter, still you are continuously supporting Abu Dhabi. That's very positive for us. And please go ahead with the session today. Thank you, sir.
Good morning, all. It's a long time. I'm having a session in Abu Dhabi chapter. Abu Dhabi chapter is always this is the first chapter that we started in UAE. Actually, it was a UAE chapter initially. Then we divided Abu Dhabi chapter and Dubai chapter. So it's always coming back home. So I was the initial first president for Abu Dhabi chapter. It's always coming back home. And I worked mostly in Abu Dhabi. So it's like most of the people I know. And it's like Abu Dhabi chapter is always at home. Thank you guys for today. And thanks for the Abu Dhabi chapter team, especially Sheikh, for giving an opportunity to have a presentation today. Before I start, let me start to share my screen. 1 minute. Are you able to see my screen, Sheikh? I think it's coming. It's showing me. How do I make it at full screen? You are able to see the full screen? But I'm getting a small screen. I don't know why it is like that. I have all these lights coming down. Maybe. Okay. Everyone is able to see the full screen, right? Okay. So again, one more time, good morning all. Today's topic, as you people know, it's about time. Okay. So when I say it's about time, actually, what today's topic, why did we select today's topic is more important. See, it appears to be a very simple topic, but this is the topic that is actually creating more denials or more recoveries are as always. Whenever you're coding a CPT based on the time, you always have a risk of denial and always a risk of take back and audits and all these stuffs. So that is one of the reason why we selected this topic. So this topic appears to be very simple. It's all about time, as we said in the heading. I want again saying that it's all about time, but it's a time which is money here. When time is going to be the money, both people, whether it is a provider or a payer, that is very important. When it comes to the insurance rules in Abu Dhabi or insurance rules across anywhere, we always say that the medical necessity part is the most important decision to pay any service, correct? So anything which is not medically justified or medically not necessary, it doesn't not to be paid under the insurance. It doesn't mean that the service not to be provided. Yes, the service can be provided, but insurance doesn't cover those services. That's the meaning of when it comes to the medical necessity. Now, when you are using a time-based code, in addition to the medical necessity for performing that service, there is an additional criteria coming in, which is the time. So that is why I said it's all about time, but again, it's the money for both parties. If you are not capturing the time properly, then from a provider side, a hospital side, a facility side, you will be losing. And from a payer side, they will be always of the belief that you are overcoding or overbilling, and finally they will try to either audit your claims or deny your claims for multiple reasons. So when we go through this presentation, you will have questions, and mostly the topics that we are discussing is a topic that you are getting the most denial or always a debate, or whenever we go for a recovery audits or the SNF audit, this is the topic that always comes in, because these are very common CPT codes that we always use. Now, let's start with the first. What is the time as per this time? What is a time? So time-based codes allows the provider to use time as an element, as I said earlier, in addition to medical necessity. So when I said medical necessity, you will ask me a question. Time is not a medical necessity. Yes, time is also a medical necessity, but performing a service, like when you are going to give a infusion, or hydration. So think about a hydration patient coming with a dehydration, and you are going to give a hydration. So the medical necessity starts with the condition of the patient, which is a dehydration, and you start the first hour of hydration. So when you're going to the second hour of hydration, this is where the time comes in. So it's medical necessity plus an additional criteria which is coming in, which is the time. The question is whether you can complete the service in 1 hour, or whether you can you need to stretch. The patient is medically justified to go for a second hour of infusion. So time means mostly in these cases, when we say time, it can be an additional unit, or it can be a most optimal CPT code also. There are two ways. Okay, sometimes a time is a selection of the you have multiple codes of time and you select the best code out of that. So that is one of the criteria. The another criteria is you can use multiple units to define that particular service. Okay, so even the time is to be justified by the medical necessity. Why? Because it should not feel like it is a stretch of the 1 hour into 2 hours. Now, what is an untimed CPT code? So there is a predefined charge for that. There is no specific time when it is an untimed CPT code, right? So you doesn't have a time that is above 1 hour or below 1 hour. So even if you perform for all day, for the insurers, they will be paying only one time. So it doesn't affect them much. They only want to look into the medical necessity part of that, whether the service has to be performed or not. But as a provider or a facility, if you are doing the same service and if you stretch for 1 hour or 2 hour or 3 hour, which is not required, then what will happen is you will be losing from the facility perspective. So this is where the time factor comes in. So whether you use more or whether you use less, both will be affecting you badly. So the optimal use of time, that is what a medically necessary situation will come in. This is what a payer will be looking into. And from a revenue optimization point of view, if you are also looking into, you always need to look which is the optimal time, the medically justified time that to be selected to performing a service. Now, as I said earlier, why insurers doesn't like mostly the time-based code is, how do you know that insurers doesn't like the time-based code? If you see your denials end of the month, you will see most of the denials may be lying in the time-based code. So insurers doesn't prefer to have a time-based. It's not a code which they prefer to have it. Why? Because for one service, the multiple units comes in. So when it comes to an e-claim, what we can justify is an ICD code. So what we cannot justify is the time, the extra time that we utilized, correct? So only the documentation which is lying in your side can only justify. So from payer's perspective, for the same fever or same infection, you gave for 1 hour, the another patient you gave for 2 hours or gave for 3 hours. Unfortunately, from a coder perspective, you cannot have any additional ICDs to support that. Whether it is 1 hour or 2 hour or 3 hour, what you're going to give is the same ICD code, right? So what happens is that from the payer's perspective, they will not be able to understand whether this 2 hours is justified or not. So the risk of denial is always there. That is why I said that they believe that it's a stretch. So the tool is in your hand. You stretch the time. So yeah. So that is what the comment. That is why the denials increases, and that's why the audits normally comes in, and that is why it have a greater risk of denials and recovery. Now, when you are using a CPT code, which is having a greater risk of denial and recovery, what is the only shield that you can put in? The best shield is the correct documentation and the correct capture of the elements which is needed for the submission. When I say the correct capture of the elements needed for the submission, it is the time which you need to perfectly capture. It may be a practice of some facilities that put a default time. There is always a risk for you if you put a default time that tomorrow if an audit comes in, whether from the Tasneem side or whether from a payer side or any fraud audit, you will be in trouble if you put a default time. So the and also the whatever time that you are going to have it in your in your XML files that you submit to insurance companies, the claims that you submit to insurance companies, that should be properly documented. Now, when I say properly documented, when it comes to the time, always any time-based code has a start and end time, and those services, when we capture into the XML, in an outpatient setup, you will not have an end time. You will only have the start time. So as a coder or a biller, whoever it is, who is matching that one in your claim. So it is a greater responsibility to them to capture the start time properly. The start time to justify the end time. So when I use that sentence, you would have understood what I'm trying to say, right? First CPT code started and end, and then the second CPT code started, second unit started. So the start time of the second unit and the start time of the first unit and the invisible end time for the first unit all should match in a proper way. Today, the insurers are using very sophisticated tools. It's not like old days. They have very sophisticated tools with artificial intelligence and very BI tools and all tools. They can easily analyze according to the program. So from a coder perspective, knowing the guidelines properly, capturing the document, capturing the time properly, and apply the rules correctly, and having the right start times for each services that you build in an outpatient setup is very crucial. And also, whatever you captured, you should make sure that there is a proper documentation in your medical record. Now the question always comes in. This is what everyone asks. That is, when we say about a time-based code, a majority of the codes are untimed codes. So untimed code, no time required. This question always comes in, right? So as I said earlier, untimed code means the code can be stretched across the encoder or across the whatever start and end of, across the encoder you can stretch it, right? As per the rules of CPT or AMA. Now, when you are using a time-based code and same time you are using an untime-based code. So from an insurer's perspective or from a billing perspective, when you look into, you used a code which can stretch for the entire encoder. And same time you used a code, which is a time-based code, which is limited to a particular time, maybe 15 minutes or 1 hour or 30 minutes, whatever it is. Now, are you overlapping your time-based code with an untime-based code? This will be the question, correct? Now, the rule says you cannot overlap, right? The time-based code is face-to-face. That means the clinician has to be face-to-face with the patient. Now, when you are using a non-time-based code, which can stretch for entire hours, and you use a time-based code for a limited hours, it is always a must. It is always a must to have a proper time for the untime-based code also. So why I say it is a must is it is to avoid your later recoveries or challenges from the payers. So it is always a best practice in your document to have a time for the untimed code also. Now, it will not be a matter if you are not using a time-based code in that particular encoder or something, but it is always a best practice. It will be always a good documentation practice for your facility to capture for time for all the codes. So thereby, whether you use a time-based code or overlap with an untime-based code, it will not be it will not be a problem for you later. So this most of us, we are using EHR. We are not using paper documents, and in 99% of the people in Abu Dhabi today, facilities are not using a paper document. You can develop your EHR in a way that you can easily capture the time of the services provided. Thereby, you will not have a challenge later on audits or recoveries. And again, whether time-based or untime-based code, it will be always, you will be capturing the time in your XML. So when it comes to the claim submission, it doesn't matter whether it is a time-based code or untime-based code. You will be able, you need to actually capture your start time. Now, the reimbursement is only depending on the rules of the CPT. So as I said earlier, payers cannot see what are the service, how the services are done. They only can see the start time. So mostly they will come back to you for audits, and based on that, the audits will be mostly based on your documentation. Now, what are the different times as per the AMA? So as per AMA, we can say there are 3 different times will be there. So that is face-to-face. Face-to-face means the clinician have a face-to-face visit with the patient. So mostly the time-based codes in an outpatient setup, the requirement is it has to be face-to-face. Anything which is not face-to-face will not be considered as a proper proper service delivered for the time-based rule. Now, sometimes for inpatient, we will be using a floor time. So like provider physically present on the patient's floor, but was not face-to-face with the patient. Delivering the services in the inpatient unit, the clinician is delivering a service to the patient. They are discussing with the directly related to the patient, something else like giving orders to the nurses. Most of these kinds of times comes in this category called the floor unit time. Sheikh, there is some message that the screen is visible or not. Are you able to see the screen correctly, Sheikh? Yeah, okay. Okay, thank you. The third one is the non-face-to-face. Okay, this is the time which is not a face-to-face. It's mostly, we can say, an untime-based code occurs when performing work related to patient before or after the face-to-face time or floor unit time with the patient. It includes tasks such as review of medical records, communication, and other healthcare providers, etc. So even in a time-based code, if you can define into 3, like a non-face-to-face time, where before a face-to-face time has started, there is a non-face-to-face time. And there is even in the floor unit time also, you have the before and after will be there. See why this is important. This definition is according to the code, these things vary. So when you are calculating the time, always keep in mind that these different parameters will be used by AMA when they define the CPT code. As you know, the AMA is the ones who's the responsible for making the CPT code. And whenever they define a CPT code, the rules of a CPT code, that always keep in mind these time rules, like whether it is face-to-face, whether it is non-face-to-face, or whether it is a floor unit time or something like that. Now let's start understanding the time-based codes. Okay, now first rule, which we always know, if there is no specific guidelines mentioned in a CPT code, what is the time required for that particular CPT, then it is the definition is mid-time passed. So mid-time passed rule, we all know, right? So mid-time passed rule, mostly the most common thing that we used is mid-time passed rule is when we code the infusion codes. Or sometimes we will use for the physiotherapy also, we will use this mid-time code rule, right? What is a mid-time code rule is, if it is a 1 hour of service, minimum half of the time has to be passed before start coding that particular service. A unit of time is attained when the midpoint is passed. Say if it is 30 minutes of code, 16 minutes has to be passed. An hour is obtained when 31 minutes have elapsed, and between 0 to 60. A second hour is obtained when 91 minutes is elapsed. So we will go detail in why 91 minutes for the second one comes in later. That is the rule. Let me one back. Shake 1 second. Shake. Oh, 1 minute. I think some slides were missing in that screen. Sheikh, I'm not able to see my desktop in this one when I'm sharing screen. That is why. Let me. This is already left or it's coming? Yeah, stop. So why that is not coming in? And the one that is showing is a different. This one. I'm not able to take it. Check it is hanged. I think I need to leave it and I'll come back. Okay. Hi guys, sorry. Sheikh, is it able to, you are able to hear, see the screen properly now? Yeah, there was some problem. Sorry guys, because its system is showing weirdly. So I was having a different presentation which was not in my system. I don't know why it is like that. So what we were talking is the first one, that is mid-time pass. So one of the most important CPT that we commonly use when it is a mid-time pass rule is the infusion coding. So infusion coding is a very common coding across all outpatient facilities, whether it is an hospital or a clinic, where most of our people always have challenges, right? So it's one of the best example for a time-based code. But most of the facilities will be using it. So the most important things that you need to know while we are using an infusion coding is, first of all, an infusion coding is, as per the CPT, there is always a hierarchy is there. We need to follow the hierarchy. The second one is there is only one initial service, right? We cannot use multiple initial services. Like you have an infusion, you have a hydration, you have a what you know as you have a push. Any chemotherapy, whatever you did, you can only have one initial service, and the order of the administration. So that's a third point. The most important thing when you're using a time-based billing for a infusion coding is that the order of administration does not determine what is the initial service. So it is the hierarchy rule. If you give a hydration in the beginning and then chemo in the second time, it doesn't mean that you should use a hydration as the initial code. You have to use the hierarchy rule where chemo becomes the primary. Normally, there will be only one initial service per an encoder unless you have two different intravenous access sites are there. The hierarchy is facility coder for not physician. This is mostly an US rule. It doesn't because we may mix the facility coding and physician coding here in Abu Dhabi. And IMSQ injections does not normally apply the hierarchy. Okay, whenever we say that IMSQ injections does not apply the hierarchy, there is no specific rule for that one. It is based on the number of unit. It is not a time-based code unit. Now, what are the documentation standards which you record? This is what the Tasnif looks into. This is not what the payers looks into. There's a proper physician order is there, where there is a medical necessity for doing the service, where there is which is the substance that is used, which is the route of administration, whether it is an IV or IM or SQ or whatever it is. What is the site of administration, whether it is it's on derma, intraderma, whatever it is. Start and stop time of each drug and substance, oleum, and the rate of administration. So these are the elements which are required to code the services. This is why initially I started saying that when you are using a time-based code, the two elements are important. One is the medical necessity for providing the service. Second is the time as an element. Time as an element is also, there is a medical necessity whether you can use the multiple times. It is a very common nowadays. Most of the payers start rejecting the second code or third code when you are using an IV infusion. So the medical necessity of using the time, that is also important. It is not only the medical necessity of using the service. Medical necessity of using a service doesn't give you the default privilege to do the extra time. So there should be a medical necessity of having an additional time units also. Now, what is the hierarchy rule? As we said, chemotherapy starts first, then comes the therapeutic infusions, then comes the push, then comes the hydration. Now, what is the difference between a push and a non-push service? Anything which is less than 15 minutes is a push, and anything more than 15 minutes becomes a infusion service. This is all we know, right? The hydration part also, we know it is whenever there is no drug is being utilized. So most of the drugs normally will be delivered through normal saline. So that doesn't mean that it is a hydration plus infusion. It is a infusion only. Now, hydration means purely it's for the purpose of hydration without any drugs being infused into that particular bag. Now, let me ask a simple one for you to understand whether this question says the patient is having an intravenous push of chemotherapy and 30 minutes infusion of Sofran, which is the drug to be reported as the initial service. So let's go back to the old one, which is it's chemotherapy infusion, then chemotherapy injection, then comes the therapeutic, prophylactic, and diagnostic infusion, then comes the intravenous infusion, then comes this is the hierarchy rule. Now you can, when you see this one, it is a push followed by an infusion. So which should be the drug? You can answer. Now comes the selection of the initial code when it comes to the infusion coding. First of all, the hierarchy comes into precedence, where you should follow the chemotherapy first, followed by infusion, followed by push, then followed by hydration, and only one initial code per encounter. Each vascular access site, why we use the word each vascular access site is because you can use more than one initial, provided there are multiple access sites are there. The order in which injections or infusions are given does not matter. So it's always go back to the same rule hierarchy. Not always the given first will be the initial. That's also goes back to the same rule of hierarchy. During most encounters, one initial will be reported. 99.9% of cases, very rarely they will be having two access sites for the same on a patient. So having a multiple initials are very, very, very rare. So the selection of the initial. So when you're a coder, you're going to code an infusion file. First, what you need to look for is what are the services provided, and as per the CPT rule, what is your initial code you need to select. Then according to the time rule, apply for the selection of the other CPT codes. Now, when it comes to the inpatient, so this is when you are selecting an initial, what the rule I was saying earlier was when you are doing for an outpatient service. Okay, let's say that this is the common rule. Now, when it comes to the inpatient services, okay, inpatient services, mostly you have seen intravenous infusions past midnight, it goes to the next day. So when we say there's a change of date, no, whether you will continue your initial or whether you will take a different initial for the second day, different, like CMS has their own rule, CPT has their own rule. CPT instructs coders based on the physician guideline, CMS instruct coders on the facility guideline. The difference is that CPT gates if a patient receives services crossing during the single encounter, multiple initial administration would apply. CMS says it's only one initial encounter to be applied. So what does it mean says, on a change of date, you can also change your initial. Like you can use a second initial on the second day as per the CPT, and you cannot use a second initial on a second day as per the CMS. Okay. Now in Abu Dhabi, there is no specific rule which is defined by DOH. So facility rules follows here. Either you follow the CMS rule or whether you follow the CPT rule. But as you know, Tasni will ask this question to you: which rule you follows in your facility before they do the audit. You cannot mix both rules. You should follow one rule. You should put it in your coding manual or coding rules that you follow in your facility, and then you need to report to Tasni before the audit what exactly the protocol that you used in your facility. Either one is fine. As per since we don't have a specific rule for Abu Dhabi, if you are following CPT, it's okay. If you follow the CMS, it's also okay. It depends upon your facility rules. So you should document in your facility guideline the rule that you follows, and accordingly you can implement in your facility. Now, here is the time comes in. As I said earlier, less than 15, we will call it as a IV push, right? Now, first you have multiple infusions where there. You selected your initial, then you found there was a infusion given less than 15 minutes. You will categorize this as a IV push. Now, anything more than 60 minutes, it becomes a intravenous infusion. 31 minutes to 1 hour is what we will call it as a 1 unit of an infusion. Okay. Now, when we say up to 1 hour, that means the second infusion will be up to 90 minutes. Correct.
Why? Because the mid time rule applies for the second code also, and also you know that one. Before starting the the midpoint rule for the second code, you need to complete the first code the entire time. So that means you have an infusion for say 90 minutes or 95 minutes, then you can code according to that. If it is on a say 90 minutes, the coding rules changes, or if it is 100 minutes, or coding rule changes. So first thing that you need to follow is the midpoint has to be passed before coding the first unit, and you need to complete the entire time plus the midpoint for the second code before starting the second code to be reported. That means 91 minutes it starts the second code. 30 minutes between the IV push of the same drug, that's also there in the rule. So this is also a time-based rule specifically mentioned when you are coding an IV push for the same drug. If it is within 30 minutes, either it has to be, if it is it's going in the on the same time or something, maybe you will be using a push code, or you will be using only one push code. Now, if it is above 30 minutes, then you can use a different push code for that one. The infusion time, the actual time over which the infusion is administered, start and stop times is very important, because you need to calculate exactly based on the time rule. So I'm not going very detailed into this infusion coding, because our topic is not infusion coding. I just giving you a heads up on the different time rules that apply for a infusion coding. So you need to understand the different time rules and apply it in a very proper way. So mid-time rule is not only the rule, you have the additional rule when IV push comes in, and you have the rule is, although the mid-time rule, if you want to use the second unit, how can you use the second unit? And what is the importance of using the start and stop time? Why? Because, you know, without having a start and stop time, you cannot calculate this exact codes when you are going to report. The challenge is, if you are using more units, you will have a risk of denials or recoveries later. If you are using less codes as a facility, you will be losing. In an outpatient setup, we all know that from a doctor's clinic, one of the main revenue that comes in is the infusion one. Now, if you are not properly capturing the infusion from a facility perspective, it is always a loss for the perspective, especially when you are having urgent care centers or emergency department. The infusion coding is a very important revenue source for that facility, and also the drug cost, which if you don't capture it properly, it will be lost for the facility. Now, in addition to that, when it comes to infusion coding, we need to understand there is a initial code is there. Yes, there is a sequential and concurrent is there, and subsequent, all different. Which, as I said, we are not going detail into the infusion coding today, and most of you know that one. That's why I'm not going detail into that one. Only just going through the what are the different time sequences and types of coding. So sequential or subsequent, mostly it is the infusion of a non-primary drug, different drug than the primary, must be given prior or after the drugs. And when it comes to concurrent, as we all know that two different drugs are being provided concurrently. Hydration cannot be considered as a concurrent infusion. And also we know that if the hydration time is overlapped with an infusion time, we cannot code the hydration time separately. This is also a part of the rule that we need to understand when we are going to code in a facility for the infusions. Concurrent infusion can only be reported once per encoder. This also we know that we cannot use multiple concurrent infusions on that day. Now, when it comes to concurrent, the most important rule is it has to be mentioned very clearly in your MIR sheet whether the concurrent is running. So other than that, it will be very difficult for you to support your justification when it comes to an audit or regarding the use of a concurrent CPT code on a encode. Okay, so the first rule we already said that when you are going to select a time-based CPT code, the most important, the first rule that we all follow is the midpoint rule. That means if it is a 1 hour of CPT, we should pass at least a mid of that. That means 1 hour of CPT time-based CPT, we can bill at 31 minutes. So if it is 30 minutes of service, we'll not be able to bill that service. Some exemptions here and there will be there, like infusions or something. Some exemptions here and there will be there. That's also that's all what you know as mentioned by CPT or AMA in their coding book. But on a broader way, or is generally when we say midpoint rule is the what we apply when we are going to code a time-based code. That's the first rule. The second one is we should use when you have the sequential typical time, the actual time is between two typical time. Use the code that the most close to the actual time. So this is also a time-based code selection. Now, mostly this comes in when you are going to code a physiotherapy type code. Like there are different codes based on time. Like there is a 30-minute code, there is a 45 minutes code, there is a 60 minutes code. Now, when you have different codes are there, and you did a service, which is a, for example, I have given here as a 46 minutes. So 46 minutes is 1 minute higher than 45 minutes, while 16 minutes higher than 30 minutes. So which is closest. So we don't look into that, which is closest or that one. We apply the mid-time rule again here. When you are going to do a physiotherapy code, if you need to select a physiotherapy code which is of 30 minutes, you should perform 16 to 37 minutes. Okay, so although we are having a sequential code and selecting based on the sequential code based on the time, but again here also the CPT is applying the midpoint rule here also. I have given in the below table, you can understand, like if it is a 30 minutes code, the mid-time rule says that it is 16 minutes has to be reached to start billing it, right? Now, when it is a 45 minutes code, that means if you come to your table, it will be 30 plus 15. So mid-time for that one is 8. Okay. Now, when you reach 38 minutes, you are reaching the mid-time for the second code. So this 15 minutes means 30 plus 15. This is the code for the 45 minutes of CPT. Now the last one is 60 minutes, right? 30 plus 15 plus 15. So again, you need to reach the mid-time. So mid-time means if you apply the mid-time plus the complete 45 plus mid-time, it becomes 53. Now, a 60 minutes code doesn't mean that you should reach to 60 minutes to report that service. 60 minutes is anything more than 53 minutes, right? And if it is 30 minutes, that means 16 to 37 you used to. So 16 to 30 is not the rule. It is 60 to 37. Why? Because 45 minutes code, which is having a 15 minutes above the 30 minutes, it also need to reach the mid-time, which is 8 minutes. So to reach the mid-time, it has to reach the 38 minutes. So you need to use 38 to 52 to reach to the to select a 45 minutes code. Okay. Now, when you are going to select the 60 minutes code, you need to complete your 45 minutes, then takes the mid-time of 8 minutes, and you reach to the 53 minutes. Okay. So here, although it's a sequential code, a mid-time rule is applied, midpoint rule is applied, and then based on that, you need to select your optimal code. It doesn't like my facility has provided a service for my facility has provided a service for 40 minutes. Does not mean that I will not be able to select this code or that code. You understood? So the rule says that from 38 minutes, you can start using the second code. Something like that. If you have a question, you can ask later when we discuss. Now, these are the different codes that we normally use for psychotherapy. So like what psychotherapy, as you know, there are, I didn't capture all the codes here. You will be knowing that psychotherapy has a evaluation code, which is 90791 and 792. 792 is mostly used for the physician and 791 is mostly for the psychologist. So unfortunately, we are not using 791 in Abu Dhabi very commonly, maybe why? Because as per the payers, they are not covering the evaluation of psychologist. Maybe that's the rule. So that's again goes back the benefit. So you can always go back to your payer and ask about the coverage part of 90791. But generally, when it comes to an evaluation, it's like a rule that is followed in UAE. That is mostly it is by the physician. Okay, although when it comes to this physiotherapy, we are doing an evaluation by the physiotherapist also. So it doesn't make sense for me. 90791 cannot be used by a psychologist because psychologists also need to do an evaluation before they start the psychotherapy. Anyway, that's a debatable topic. That's totally out of our discussion today. 90792, which is the evaluation code, and then comes the psychotherapy codes. When it comes to the psychotherapy codes, again, you will have if you are the old days, we had a single code which defined an E&M services, evaluation services together with that psychotherapy code. But now we have a new set of code from 2018 where it says you can build the E&M service separately. So that means psychotherapy with evaluation and psychotherapy without evaluation. So if you are doing a service, if a physician is ordering a providing any service which is related to evaluation, or any services which is psychotherapy, that helps you to decide. You need to have so when you are making your, when a physician is going to document, it's two different elements that is going to be there in the medical report, right? One element which should cover your E&M, which is you will be coding by the MDM part, because mostly in Abu Dhabi we don't follow time-based coding for E&M. So you are following a medical decision-making rule for while coding the E&M in Abu Dhabi. Now, in your documentation, you should be able to differentiate or distinguish between the two documents. One for the selection of the E&M code that you selected for the evaluation and management services. When I say evaluation management services, means those services which is from the diagnostic perspective or a follow-up perspective, a physician is going to perform for the patient's psychiatric condition, plus any orders, prescription, or anything that is the physician is going to provide on that particular day. Okay, now a psychotherapy is totally a therapeutic services, so that doesn't contains an evaluation. Although I say it doesn't contains an evaluation, it also applies any CPT rule which says that if you are going to perform a CPT code, the pre-services for performing the service is always included in the CPT code. You know that rule, right? Now, when I say pre-services, so any service that is done to do the to perform the psychotherapy on that particular day, so that is already included in the CPT code, right? So this is what we call it as significantly separately identifiable, right? So the 25 modifier rule comes here. So when you are using an E&M and when you are using a psychotherapy on the same day, you need to distinguish the evaluation part, which is performed on that particular day. This evaluation is not a typical preoperative evaluation to perform the psychotherapy services. It is a proper evaluation which can be coded separately as a different E&M. So when you are going to perform your key elements, which is the MDM part of it, you need to segregate from the documentation. So from a medical documentation perspective, from a revenue cycle perspective, from a CDA perspective, you need to develop a documentation for your physician in a way that they will be able to capture, or they will be always performing E&M. I say they will be performing, but I'm saying they will be properly documenting the E&M part of the one that you performed plus the psychotherapy part. Otherwise, it will be always having a risk of denials or risk of the payment recoveries, because there is a code which is only psychotherapy. There is a code which is psychotherapy, plus you can code and E&M separately. Because of that time rule of the code, and see here again the time rule comes in. You are doing a non-time-based code. I'm using the sentence against non-time-based code because we are not coding E&M by time here. So let's consider E&M here as a non-time-based code that we are applying today here. And when you are using that non-time-based code today with the time-based code, which is the psychotherapy code on the same day, then you need to distinguish from your document the time, and also you need to distinguish the document. Why? The evaluation to do the psychotherapy services, which is the already included in the, which is significantly, you should significantly separate it from the evaluation and management service that you are going to bill it separately. Okay. It's not so complicated. If you define it properly, it's an easy process. So for the better of coding and better of the documentation, if you are having a psychotherapy, better to have it properly defined in your document so that it will be always better for you to code, and also better for you to better for your physician to document your services. The risk of recovery or denial will be lesser if you define your documents properly. Now, time for psychotherapy session, this we already discussed, like time for each psychotherapy should be documented in the medical. Yeah, okay. So this is one of the important criteria when it comes to the documentation part of the psychotherapy services. So because the psychotherapy services, we are purely depending on the time, where the E&M services on the same day, we are going to do without any time. Okay, so there it is an MDM part. So time of each psychotherapy services should be documented on the medical claim, apply the CPT time rule, and choose the code close to the actual time of the session. The time for each psychotherapy session is described as the time spent with the patient and family, and time for each code is specific. So patient and family is a CPT rule, and how do your payer, like we have different payers here. So how do your payer is going to apply their rules? Follow the rules according to that. It's a general statement, patient and family. Some payers may not accept the family part. Some payers may accept the family part. But that's all varies according to the payer's responsibility. In a general sentence, it is the time spent with the patient or family. So when it comes to psychotherapy, it's also a protocol that it's not only giving therapy to the patient, it also a bit on the family members also, because they are the one who is making sure the patient is being taken care of properly. Okay. Now, the last part of the time is the E&M part, right? So in E&M also, you will be seeing this is the third time. There is a fixed time, like E&M 99213. There's a fixed time like 15 minutes or 30 minutes or 45 minutes. There are different times are there. Okay. Now, how do you select? It's an approximate time. Okay, it doesn't mean that once you pass the mid-time, you can code that. That rule doesn't apply for an E&M. Okay, so the first rule we already talked. The first rule is a midpoint rule. The second one is select sequential codes. When it comes in, you select the most appropriate code by applying the mid-time rule. Although, like why I used it separately is if you apply the mid-time rule only for the second rule, then you will be selecting it like 45 minutes, mid-time 22.5. That is not the rule for the second one. In the first one, it was a mid-time rule where if you reach to 31 minutes, you can bill it. Second, it is not the mid-time rule only. You are using this, you are going to select the second code, but you are not going to use a mid-time rule. It's not an add-on code. It's each and every code stand individually. The other one was when you're using the units, it's an add-on code. So add-on codes rules are different from the when you are having an independent codes to select. So their mid-time rule is applying, plus the additional rules that we already discussed has to be applied. But when it comes to the third one, which is there are time-based codes, which says a fixed time is required when it is coded. I will say that VNM time-based code time rule is not properly applied in Abu Dhabi. So since we are talking about a topic which is time-based, I'm using this discussing this topic also with you people. But disclaimer, you apply in Abu Dhabi, that is according to the payers, according to the rules that you follow in Abu Dhabi. Okay, I'm just giving you the rule here. Okay. When it comes to a ENM, like it is not going to apply the mid-time rule properly, right? So it is an approximate time. When we say 15 minutes, it's an approximate time. But the most important thing that you need to understand is 50% of the time is being utilized for the counseling and coordination of care. Okay, so that doesn't mean that if the patient time is only, I mean, like 15 minutes of ENM, if it is performed for 7.5 minutes, we can bill it. No, this is not the meaning of that one. So there is additional time is there. That is more than 50% will be there. But while billing it, 50% of the time utilized should be for the counseling and coordination of care. That is the definition of the using of time for the ENM. So when counseling and coordination of care constitute more than 50% of the physician or patient or family encounter, that is face-to-face in the office or outpatient setting, time may be considered as a key or the controlling factor for the to qualify for a particular level of ENM. So we know that ENM, there are 7 different elements to selection of an ENM, and out of that, time is one element. And the rule of selecting the time for this one element is the 50% of the time is used for counseling and coordination care. Again, this counseling and coordination care is also one of the element in an ENM. That also ENM selection, that also we know. So the time rule applies when you are going to do the counseling and coordination of care. When is the majority of the services provided on that particular visit, it is not by the key elements, but it was by the counseling and coordination of care. And on that counseling and coordination of care, the total visit time 50% or more is counseling and coordination. Then only you can bill the service. Okay, this is the third time rule that we normally apply. So what are the counseling and coordination care? Counseling is the discussion with the patient or family concerning one or more of the following areas. Discussing the diagnostic results, impression and recommended diagnostic studies, the prognosis part of that, risk and benefits of the management treatment options, instruction for management, treatment and follow-up, importance of compliance with the chosen management, that is treatment options, risk factor reduction, family and patient education. So this is as per the CPT assistant. The different rules pertaining to the counseling of what are the different elements which we can call it as the counseling and coordination of care on that particular encounter. Now let's go to the time rule. Again, this is the time rule when it comes to the midpoint reached. Okay. This is a very important rule that we use for the physiotherapy, which is the 8-minute rule, which is the CMS rule. Okay. Now, what is an 8-minute rule? It's also a midpoint rule where the first unit starts from 8 to 22. So 8 to 22 units. That means we know that most of these CPT codes in the physiotherapy, I'll say not even most, all the physiotherapy units are mostly in the 15 minutes, 15 minutes, and midpoint reached is 8 minutes. So we'll apply first unit when the service is provided for 8 to 22 minutes, and 23 minutes to 37 minutes, it becomes the second unit. And when it is 38 minutes to 52 minutes, it will be the third unit can be utilized. And 53 to 67 minutes, it becomes the fourth unit. and 62 to 88 minutes, 82 minutes, 5 units, likewise. Okay, so if you notice here also the same things, same rules apply. Like first you need to complete your initial total time plus the midpoint rule. This is the same thing like what we noticed there when psychotherapy codes were there. It's applied the same rule. Like means if it is a 15 minutes code, the 15 minutes has to be completed. That means 15 plus 8 becomes 23. That is why the second unit starts at 23. 15 plus 8. The midpoint is the second one, which is 8 minutes. The first unit has to be completed 15 minutes. It doesn't mean, see, it is like you used two different services, okay, two different services, but total minutes used were 22, but still you will be using only one unit, whether the first one or second one, right? So it doesn't go by the services you provide. Okay, you provided two different services of physiotherapy services, and total time utilized was 22 minutes. Still, you will be billing one code. This is the meaning of this time rule. Okay, you cannot use multiple CPTs there since your time element didn't qualify for the selection of second code, although you perform that particular code. This is the same rule when you come to the what you know as infusions. Also, this rules comes in. Okay, so this is how it works. The 8-minute rule governs the process which determines how many units should bill to insurers for the outpatient services provided on a particular date of service. So earlier, mostly these units were not very strongly applied in Abu Dhabi. The 8 minutes rules were not strongly applied in Abu Dhabi. But nowadays, as you know, Daman has already sent out a circular, and most of the payers are now strongly following this 8 minutes rule in Abu Dhabi. So this is the classical CMS rule for an 8 minutes rule. Now, is it same as CMS and AMA? No, AMA rule is different. So it is called 8S minute rule. It is not the 8 minutes rule of the CMS one. So what is the difference between the AMA CPT rule and the CMS rule is both the rule number one is same, midpoint reached. For the CMS, to selection of the second code, only the midpoint is not enough. You need to cover the entire 15 minutes for the first code, irrespective whether you provided a second services although during that period. Okay, when it comes to CMS, when it comes to AMA, they don't look into that one. They will be looking only for 8 minutes rule. Like, if an 8 minutes is over, you can do that. You can build the service. Next, another 8 minutes, you can build another service. So they doesn't look for whether you finished your 15 minutes for the first code before selecting the second code. This is the difference between these two codes. The rule 8 says follow the same principle of 8-minute rule, but it is calculated per service, not by the. In other words, a clinician needs to perform half the service time outlined in a time-based code before bill for 1 unit of that code. The time codes physical therapist usually is 15 minutes by definition, which means at least 8 minutes of the unique service must be performed to bill 1 unit of that service. It is important to point out that the rule of 8S only applies to relevant time-based code that have 15 minutes as the usual time in the operational definition. So normally 15 minutes is where we don't use that 8 minutes rule when it comes to the psychotherapy or something. When there is a code which is defined for the 15 minutes, we will be using the mid-time rule here. But there is two different rules. One is the CPT rule and one is the CMS rule. CPT rule says when you pass the mid-time, it is based on the services. If you did 4 services, and if the mid-time is passed, even when I say 4 services, even you are using the same service, that also it applies if it is the mid-time is passed for that one. So when I say service rule, don't get confused on that one. So mid-time says if you used a CPT code, let me put it in a different way. Any CPT code which is having a 15 minutes, if you perform for 8 minutes, you can bill it. Okay, now if you are using the same therapy for 15 minutes, as per the AMA rule, you will be billing only one code. Now, in a 16 minutes time, let me put it in a different way. Totally, you spend 16 minutes for that physiotherapy. When it comes to the CPT rule, you can bill 2 services, right? 2 units of that service, whether it is same service or different service, you can bill 2 units. Why? Because you are applying the 8-minute rule. So in a 16 minutes, you are qualified to bill 2 units. While in a CMS rule, you cannot do that one. You need to first apply the midtime rule, midpoint rule, which is 8 minutes, then complete the 15 minutes, which is 20 up to 22 minutes, and 23rd minutes you can start billing the second code. So if you do a service for 16 minutes, you can bill as per the AMA, you can bill 2 codes, but when it comes to CMS rule, you can bill only 1 code. Though this is the difference between these two. Sorry. This is the difference between these two rules when it comes to the time selection of selecting the code. എന്താ ഷേഖ്? ആ രമണ ചേട്ടാ ഓ ബാക്ക് പോണുമാ? ഇത് ഇത് ഓക്കെയാ? இது சொல்லியாச்சா? Sheikh, this one I'm sorry, I didn't notice that it was muted. This one you heard? Okay, this one no, right? I'm sorry. Okay, so what we were trying to say, okay, okay, so what here I was saying in the last minute is giving an example of a difference between a time-based and a non-time-based code. Okay, sorry, I'm very sorry. When I was giving a difference between an AMA 8 minutes rule and a CMS 8 minutes rule. Now, as I said, AMA CPT 8 minutes rule go by the 8 minutes of incentive for the each code. Okay, if 8 minutes is 8 minutes is over, you can build the service. The same rule applies for the CMS also, but for selection of the second code, you need to finish the 15 minutes, right? Now let's see, a 16 minutes of service is being provided. Okay, now as per the AMA CPT rule, you will be building how many units? 2 units, because you have 2 8 minutes of services being performed, right? 2 different services, each 8 minutes, because it's a service-based billing. Once you used an 15 minutes code and 8 minutes is already passed in a CPT rule or AMA rule, you can build 2 units of these services. Whereas in the CMS, you need to reach 22 minutes before building the second unit, correct? So that means 23rd minute only you can build the second unit of services. So this is the difference between AMA rule and the CMS rule. So most of the payers in Abu Dhabi, they started using the CMS rules now. Especially you would have received the circular from Daman and some other payers also following the CMS rule, which is 8 plus 15 before selection of the next code. Okay, so that applies for each and every code because all these codes are 15 minutes. So it keep adding 15. So once you initial code 8, then 15 minutes increment only you can report your additional code. While in the when it comes to the AMA, every 8 minutes you can keep building your additional code. So when I say every 8 minutes, a service should be different. If it is the same service, it has to finish 15 minutes. Then you use the next unit. If it is a different service of physiotherapy that is using your coding, I mean, then you should only reach only 8. You can 8 minutes only to be reached. Correct. Now, when it comes to the time-based unit versus service-based unit, service-based units are the untimed units. So this is the one that I was saying when I was in mute. So when we say service-based unit or untimed unit, what are the services that we normally provide is evaluation codes or the hot or cold packs or electrical stimulation or something. So although we say these are untimed codes, by rule, it cannot overlap with a time-based code. Okay, time-based code, we all know that it is a face-to-face code. While this is more an example for a floor unit, like the technician may not be or the clinician may not be physically present with the patient, although they are in the floor or in the physiotherapy. They started the service and they would have went for the to provide the service for another patient, right? So they are not there physically with the patient, but it should not. And also we know the rule is the rule of untimed code is it can stretch across the encounter. So to define or to prove when an audit comes in that, oh yes, it's an untimed code, but I used only for 5 minutes or 6 minutes or 7 minutes or 10 minutes, according to whatever the medical necessity, you need to have a start time and stop time for the untimed codes also in your physiotherapy documentation whenever you are using a time-based and non-time-based codes together. Otherwise, it will be difficult from a audit perspective to show or prove that the untime-based codes were not overlapping with the time-based codes. Yes, when you are capturing in an XML, you will have only the start time, and this start time also, as I said earlier, should not be in such a way that it will be overlapping with the billing rules of CMS or the payers that we follow in Abu Dhabi. Now, when it comes to the time-based codes, that is mostly direct one-to-one. It is face-to-face. It is 15 minutes direct therapy. These are the codes used for one-to-one constant attendance procedures and modalities such as manual therapy, neuromuscular re-education, gait training, ultrasound. Here, we follow the 8 minutes rule plus the 15 minutes increment rule, and then we'll select. That means every code will have a 15 minutes of gap after the 8 minutes. Like first is 8 minutes, second is 23. Now for the next code, how do you select? Add 15 minutes. You will reach 38 minutes. The next code plus 38 plus 15, it is 48 plus 5, 53. So this is how it goes, right? First 8 minutes, then each additional code is 15 minutes after. That is CMS rule. And if it is AMA rule, first is 8 minutes. If it's a different service, then you can have an additional in second one in the next 8 minutes. If it is same code, first finish 15 minutes, then take the second code. Then again in the 8th minute you can do it. Now, if it is same service, you in an AMA and CPT, it will be 23. If it is different service, in an AMA, it will be, if it is 23 minutes, it will be, I mean, if it is 22 minutes, think about that. There's a 22 minute service performed. If it is CPT, you will be billing 2 codes, while in the CMS, you will be billing only 1 code because you didn't reach the 15 minutes increment where the other one you already reached. Okay. Okay, how can I tell an untime-based code from a time-based code? It's very simple. In every code description, it will be mentioned very clearly the time required. If it is 15 minutes, it will be 15 minutes, or if there is any specific rule for that particular code, it will be mentioned like evaluation and send. I have given an example. 92620 and 9261, where it is saying evaluation of central auditory function with report. Initial 16 minutes is reported for the first hour of evaluation, and each additional minutes can be reported multiple times if the evaluation lasts more than 1 hour. So in this case, you need to complete your 60 minutes. Then for each additional minutes, you need to use the 50 minutes increment. You cannot directly apply the 15 minutes mid-time rule here because the rules are different, and time has no associated time in their descriptor. So it means 30 minutes if you perform, don't bill 92620 and 92621. That's not the meaning of that. Now, time-based code. The time associated with each CPT code includes the pre-services. Mostly, this is where the time-based codes comes in. The time associated with each CPT code, it will have a pre-service before you see the patient, intra-service or one-to-one evaluation on the treatment. This is where we will bill it, which is the intra-service unit, because for a time-based code, it has to be face-to-face. And post-service unit after evaluation treatment has been completed. The pre and post services includes the time spent reviewing records, preparing session, discussion results, caregivers, report writing, communicating with healthcare provider. Because these included in the value of each code, they generally cannot be billed separately with additional codes on that. So that time will not be calculated, which is already included in the. So this is the one which we say a CPT code includes a pre and post, which is already included in the CPT code. How do you select the time-based CPT code? It is by the face-to-face time. So although it has a pre, a post, and a face-to-face, the selection of the selection of the code is based on the face-to-face, while the pre and post is already embedded into the face-to-face. So now, why I use this slide is most of some audits, some payers come and see the schedule part and all these things. So if all these gets overlap, so you will have a risk of take backs and all these things. This is most important when you're calculating this time. Now, the last point in this category, let me touch base with some of the other codes, that is telemedicine codes, which we normally use in the billing for Abu Dhabi, where the time is again being used. Here there is a time 5 to 10 minutes of discussion. So you need to cross that 10 minutes, and the next one starts from 11 to 20 minutes. So there is a it's not end set. So 5 minutes you can bill it. Doesn't mean that if you use the you apply the mid-time rule and you apply the second code. No, that's not the meaning. Up to 10 minutes. Okay, so they specified it very clearly, not like a psychotherapy code where the second code starts at 11 and you have to bill up to 5 to 10 minutes. So this is very clearly mentioned in the code itself. So 5 to 10 minutes, it becomes 99441 and 442. And what are the telemedicine codes normally that we use in Abu Dhabi is the normal consultation telemedicine that we will use. And also for the psychotherapy nowadays, we have some telemedicine codes which we use in Abu Dhabi. Okay. So these are the common services that we use for Abu Dhabi billing, and it's time based. Most of the rules, as I said from the beginning, it is midpoint rule. Some services it will be mentioned the code itself, the time you need to follow the time. Now, if it is not mentioned, then the midpoint rule applies, and midpoint rule we follow in Abu Dhabi is mostly the CMS type, where the when you are using the second unit or second service, you need to first complete the 15 minutes for the first unit, and then you go for the second unit. Okay, when it comes to some other kind of billing like psychotherapy, when you're selecting a code, the invisible mid-time unit has to be taken into consideration before selection of the second code. Although and also the second code, although it will be having a time which is like 45 minutes or something, but you can start earlier. Because you need to apply your midpoint rule. Although it is not an add-on code, still it is up to 45 minutes. You can use it up to 30 minutes, up to 45 minutes. You can use it. You need to apply your midpoint rule and select your code according to the best suitable code, which will falls under the midpoint rule. So there is slight difference. And when it comes to the E&M, as we said, it's again midpoint rule, but midpoint rule doesn't apply selection of the code. Midpoint rule is applying for a particular service, which is counseling and coordination rule, coordination of care. And the remaining services, it doesn't be calculated for the selection of the time or the selection of the code. Considering the time for the selection of the code, it is only the midpoint will be considered when you apply the E&M. And when it comes to the certain codes like telemedicine, you have a range of time is provided. You need to cross that range. And there are certain codes also, like I showed earlier, when 1 hour increment and additional that one, then you need to cover that one when you are starting the next code. So these are the most important things. Now, as a documentation, when it comes to the time rule for E&M, we will say that you should document, the physician should document properly the entire time used for the counseling and coordination of the care. Now, for other services, the start and stop of each services to be recorded. This is must. It is mandatory. You cannot deviate from this rule. Then you will not be able to. You will not be able to what you know as code. But although the service is being provided, if you doesn't know the start and stop time as per the CPT or CMS or DOH, whatever be the rule, you will not be able to do code that particular services. The physician must include a record of total time of the visit as well as the time spent in the specific counseling and coordination of care activities. So this is also important. Why? Because it is 50% of the 50% of the total time. Unless you doesn't know the total time, you cannot calculate whether the counseling and coordination was 50 minutes. So if you say, a physician says, I spend 30 minutes for counseling and coordination of care, that 30 minutes should be mid-time passed of the total time. If it is not, like it was a 2 hours of stay and 30 minutes, then you will be selecting a code based on that. So this is also very important. Secondly, note that should include the summary of the content. So not only saying that they did the counseling, but what are the services that provided during that counseling is important. This is also important when it comes to the psychotherapy. The rule is very important. Like psychotherapy, we are selecting by the time, but what kind of services they provided during the psychotherapy is also important. Why? Because we need to separate the E&M part, which is significantly separately identifiable from the E&M part. So this is also very important. Okay. Thank you, guys. These are the common rules that we apply for time-based coding here. So if you have any question, you can ask now. Sheikh.
Okay. Guys, I think your mics are on mute. We can ask any doubts if you have.
When can we get serious? CUs?
Yeah, CUs, I think it will take 7 days to 1 month. Okay, we will correct the CUs. So if you have any doubts, you can ask doubts.
Okay, I have one doubt. Hello, can you hear me?
Yes. Who is on the line?
Okay, I have one doubt regarding the billing of additional IV hydration. Okay, this is a billing related question because if we are giving only hydration, the amount will be 70 dirhams. But if we are giving an IV push and after that we are coding an additional hydration, then we will get only 20 dirham for the hydration. How we can justify that? Because we are giving two services and we are getting only less payment.
So you are saying about the add-on code hydration, right?
Yes.
Okay, so see, a service codes includes a lot of now when you calculate a CPT code, there's a lot of elements in the on that particular CPT code. It is CMS or AMA calculate based on what you known as the relative value unit, right? So this is not a time-based calculation. It is based on what exactly we call it as the relative value units and what are the inclusion services that are included into the CPT code. It's having the pre-service, post-service, and all documentation and everything included. Now, when you're using multiple codes, all the other elements other than providing the exact service, it is being removed, and only the providing the service will be calculated for the add-on unit. This is basic logic. Now, you are again talking about the money value. That is something that you need to raise to health authority. So if you have a question on whether that is not correct or not, why? Because that part is we cannot explain or we cannot say that one. Maybe your point is very valid. The cost of the medicine may not be reaching to that amount that you are going to get. But it's not a billing question also. This is something a regulatory like question. So yeah.
Okay, so the other question is, can we combine an IV push and additional hydration to an infusion? Then it will match the overall cost. That is another.
No, you cannot do that. By law, you cannot do. By CPT rule, you cannot do that. You cannot.
Okay. Thank you.
Thanks.
Hello.
Good morning. Good morning, Mr. Sunil.
Good morning. Good morning. How are you?
I am fine, thank you. Can we have an query on the dental time-based course? Like because every time in a dental, it is always mentioned as a unit of time. So, do you can you explain on this, or is that? I don't know whether
Today
I can
we
query this on that because you didn't mention anything about dental, but I have a query regarding time-based in dental.
see yeah, correct.
No, since it was a time based, since it is a time based presentation, so I thought like maybe it will be an under dental also it can be queried or whatever. It's okay.
Dental
So
coding that we follow in Abu Dhabi, you see, if it is CD, sorry, Sheikh, if you follow the CDT rule, it will be the 15 minutes increment rule will be. See, there are two types of dental. See, what we what we are talking today totally on the CPT rule, right? CPT has a dental. It's called CDT, which we don't use in Abu Dhabi. Although you can use it, but we are using the USCLS, which is the Canadian coding system. They have a see Canadian coding system. We totally didn't implement in Abu Dhabi in a proper way. Okay, so you know that Canadian coding, even the time units or addition units or anything, it was not properly utilized in Abu Dhabi in a complete way, like CBT. Okay, now any rule that you are going to apply, you cannot apply in a proper way because even additional units are not currently defined. What is defined in the Canadian is different from what we use. So I will say mostly it is a customized model, which is we use in Abu Dhabi, the Canadian one, right? But CPT, it is not like that. It is not a customized one. We are following the entire CPT in Abu Dhabi. While see this Canadian one, we are customized too much on that one. So customization again goes back to the payers, rules, and all these things. So answer to your point, mid-time rule mostly passes because that's also they defined, but it varies. So code to code, it can vary. So I'm not giving a final answer because it will be like Sheikh said. Somebody who is going detail into the dental, they will give you a correct answer. But mid-time rule is mostly applied, but not in a proper way because it's not a CPT coding system. It's totally a different coding system. Thanks.
I understand. Thank you. Because it is only a CPT presentation, but I thought like time based, so I can query on it. Thank you very much for clearance.
Thank you.
Okay, to which email can I? Sure. 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 Thank you very much for the clarification.
Hello, Mr. Sunil. Good morning.
Hello. Yes. Yeah. Good morning, Dave.
Yeah. Actually, I have one doubt regarding E&M documentation. Like, as you said, it's a time-based code. So, is it mandatory that during submission level we have to capture the start time and end time?
No. See, E&M actually, E&M has 7 elements, right? So out of the element, one of the element is the time. Okay. So now you can select the E&M based on your key elements or by the time element, which is again going back to the counseling and coordination of care. And also the presenting problem has to be matched. All these things we know as these are the basic guidelines of an E&M part. Okay. Now the question is when you are if you are selecting an E&M based on a key element, which is as per the rule that we follow in Abu Dhabi. We don't follow the time rule in Abu Dhabi because this was decided long back by CCSE. So you doesn't need to capture your time, but you have a default time as in the XML. So you capture your correct time. But anyway, you cannot show your stop time in an XML in Abu Dhabi. Because you have only the start time for each activity. So you have 3 activities there. You can show only the start time. You can have a end time for an encounter possibly if it is inpatient, but you cannot have it. So answer to your question, I will prefer you to capture your start time correctly, but end time anyway you will not be able to capture. but time is not an element.
So for the
we
time-based
calculate
code, it's yeah, I understand. Like, but for the time-based code, as per the new circulars, it should be we should capture the start time and end time, right? So so as the ENM is categorized as time-based code, then it should be captured, right? This is my question, because in my
ENM is
facility
not
I had recoveries. Yeah.
sorry.
So in that in that the payer told that you have to capture the start time and end time. So for that my query raised. So this is my doubt.
No, it is
as
not.
you
It
said,
is not that you can. Yeah, you can go back
mandatory,
to the payer
right?
and say, see, yeah, it is not mandatory.
Yeah.
See, ENM is not a time-based code. ENM, one of the element of calculation of ENM is time. This is how ENM comes in. See, if you take a physiotherapy code, which is a time-based code, the only element of calculation that is time, correct? An infusion code, the only element of calculation that one is time. But ENM, one of the 7 elements is time. Now, if you go by the key elements, time is not the factor there. You are going by your history, examination, and medical decision making. Now, I don't know how do you calculated your ENM. If you are calculated by EMDM, you can go back to your payer, say that, see, guys, I calculated this ENM based on my MDM. I didn't calculate by the time. So there is no start time and stop time for me. And it is by the MDM. Again, the payers, for the technical reason, nowadays, many payers have started taking an average time for a consultation and calculate if you have 10 consultation by a physician and each consultation this much time. So in an 8-hour shift, if the physician has completed, whether they can do this consultation. Some payers have started rejecting even at the eligibility level. If they found that there is more eligibility is being requested than their average standard time. This average standard time they calculated is based on some internal rules they created. It is not something that is the CMS or AMA or DOH rules. Okay. So answer to your question, no. If you applied MDM as a rule in Abu Dhabi, then you don't need to capture your start and stop time. This is not the element you use to calculate the ENM.
Yeah. One more question. In the EMR, is it needed to capture the start time and end time, like direct face-to-face time with the physician? Is it mandatory or not?
See, it is not mandatory to have a face-to-face. It is not required because unless, see, are you using ENM as the time as the element for calculating ENM? Which is the element that you are using to calculate the ENM? Is it MDM?
We are
is
not
it
using,
key element?
Yeah, MDM. Yeah, MDM part.
Key elements.
So,
okay, so that is
yeah,
your
key
medical.
elements,
You put
yeah.
it. Okay, so you follow MDM. You doesn't need to. You are not following the time-based coding at all. See, time-based rule of start and stop time comes in when the selection of the code is fully based on time. But ENM, one of the element is based on time. It doesn't mean that you need to have a start and stop time, and one of the element is only time.
Okay. Thank you. Thank you, Mr. Sunil.
Hello, Mr. Sunil.
Yeah, good afternoon. Good morning, sorry.
Yes, yes, good. Yeah, I just want to clarify whether we're following this midpoint rule under the services, like the
what
OT
rule?
charges, like when services, like DSL Dubai service list or the
Okay.
theater charge. We have this 20, service code 20 and 20.01.
Okay, you are saying about the midpoint rule. Again, you see.
Yes.
Okay, now let's say what is this midpoint rule? It is a CPT rule, right? So CPT has a proper calculation for each and every CPT codes. Same AMA have a proper calculation of CPT codes based on something they call it as a relative value units. And when it comes to a CPT code, it's not only the providing the service. There's a pre-service and post-service. There's an intra-service. So a lot of elements are part of the CPT code. We always say whenever we see a CPT code, we are thinking CPT code is just to do the service. No, it contains a lot of things like a minimal event. Say a patient coming to a hospital with an injury And if it is a pre-service is an evaluation, which is only to do that service, that becomes part of the CPT code. You cannot bill an E&M separately. That is the law of Abu Dhabi, right? So these are all why we are applying these rules is because a CPT code is created in a way that the pre-service, intra-service, and post-service is included into the CPT code. But when it comes to the service codes, which are created by DOH and DHA, we cannot properly apply the mid-time rule because it may not be inclusive of all these elements as defined by the CPT, unless DOH or DHA clarify saying that it is included. We cannot. But as of I am knowing it, they never has classified that one in a way that you can apply the mid-time rule there. So for me, we need to complete that entire time because they never defined that mid-time rule can be mid-time rule can apply for these codes because it's an internal code.
Okay.
Mm,
Okay.
Yeah.
Thank you so much.
yeah.